Diabetes is a talk that's really changed over the course of the last 15 years since I started in the field of medicine and got my training. I know there was a talk about robotics, and I'm sure I'm contributing to a lot of robots. I prescribe a lot of drugs, and with all those drugs, one of my few handouts that you should have, I wanted to put a list of some of the current diabetes medications. I included brand and generic names because as much as I can remember to stick to it during the talk, I'm going to go with the generic names, and there's a lot of new drugs with hard to say words. So keeping track of how you're familiar talking to them with the patients, I thought this would be helpful. And as he's talking about the cost of the PCSK9 inhibitors, many of these newer drugs are not cheap, and at least I'm sure the pharmaceutical companies will tell us part of that is due to some of the studies we'll cover later. These are bigger, longer studies for cardiovascular information. There's another handout that's in there that I'm not really going to cover with this talk. This is just one I generated in my office because the days of easy insulin, and insulin's never really easy, but at least prescribing it, you had a vial with 1,000 units, and then pens came out, and each pen had 300 units. And now we've got all these concentrated insulins and mixes and all that kind of stuff. And to make sure that you're prescribing the patient the right amount for the supply, I put this grid together, number of units per dispensable pack. You can order correctly. And that's really all that's there for. We talk about diabetes and increased risk of dying. And when we look at the causes of death in 2015, which were the most recent causes of death that I could find published, cardiovascular disease is at the top. Diabetes comes in 7th, but there's obviously going to be an underrepresentation in terms of how much diabetes is impacting the risk of dying from all of these other things. So we know that diabetes can increase the risk of chronic liver disease, kidney disease, cerebrovascular disease, and heart disease. And so we're not going to get a good statistic on how much diabetes is really contributing. While I was asked to talk about the current state of diabetes medicines and their impact on cardiovascular disease, I always start with lifestyle management. And if you give me an extra minute or two, I'll say a few more words than I was planning on this slide. But this is a pretty recent study, 2016 published, so a lot of the slides that I'm going to talk about today, there are a few old ones, but many are just in the last 2 or 3 years. But this was a lifestyle intervention where for the first 6 months of a trial, people got weekly meetings either in group or individual. The second 6 months of the trial, they got a few less meetings, and in years 2 through 4, they had 2 contacts per month. And contacts, it sounds like one of those was a phone call, one of them was either a group or individual. And this was in type 2 diabetic patients who were overweight or obese, wide age range, and while the intervention was only 4 years, they had a 10-year median follow-up. And if you lost weight, and about 2/3 of people did lose weight, if you got to that 10% weight loss, the primary outcome was a 21% decrease in the composite cardiovascular outcomes. So keep the 21% in mind with 10% weight loss when we start looking at the outcomes we're talking about with these new diabetes drugs. So I do probably have somewhat longer visits for my diabetic patients, and when I'm talking to people about the health, lifestyle, how much to work on diet and exercise, I think people are going to benefit from weight loss, and giving very concrete dietary advice is hard because there are very few long-term outcome studies looking at diet. Diet's very hard to do in studies because most people are not going to stick to the diet, so you can do intention to treat trials and it's not going to look like it works. But for the person who wants to really stick to the diet, how much does it really work? There's very little data. I go back to overall calories with the goal to lose weight. I tell people not to drink their calories. Other than really milk, I think is important as we're aging, bones, lots of different reasons. But water, milk, we drink coffee, we drink tea, we drink alcohol in moderation. But to avoid all the power drinks, the sugar drinks, juices, all not good for us. After drinks, I ask people to start thinking about trying to limit the amount of processed foods. And we may not think about it, but we're getting into chips and bread and everything. Trying to eat more of the kind of whole foods. They are not pre-processed, so your body takes a little bit more time to digest them. You're probably going to feel fuller. And this is how we really evolved. And then I can get into more nitty-gritty, and people have certain specific concerns. If it's the triglycerides, I really try and stress the low fructose. So you're getting rid of fructose from the diet completely. in terms of any of the high fructose corn syrups and things like that. So exercise is important, and in terms of the exercise part, there may be a component of you're doing enough exercise, but there really may also be a part of how much of your day you sit on your butt, even if you do 30 minutes of exercise. If you're relatively active the other time that you're awake, there's probably a benefit compared to you spend the rest of your life sitting down. So that's one lifestyle study that shows some benefit, and this is just one bariatric surgery study. So you do bariatric surgery, weights come down, and there were fewer cardiovascular deaths. These are not going to be as robust as some of the other studies that we're looking at, because really at baseline there's very few people who have known cardiovascular disease, and there was only a small percentage of people who have diabetes. So you cannot equilibrate this to some of the studies we're going to look at later. In terms of the cardiovascular medication history, Dr. Wang has already talked about statins. You know, what I would consider a cardiovascular drug, aspirin, 1899. At that point, I looked up the leading cause of death in the United States, and it was some version of pneumonia or TB. So cardiovascular death was not high on the list. Nicotinic acid being recognized as affecting cholesterol is only in the 1950s, as are the first beta blockers, and captopril in 1981. I knew about GLP-1s from the Gila monsters. I didn't know about captopril from Brazilian pit viper venom, but I guess so. And then the statins in 1987. He's already talked to you about lipids, so I'm going to move on from that. But from cardiovascular risk reduction, we do have some studies that show that blood pressure is important, and this is a study in diabetics where you have decreased cardiovascular events, and this is just looking at diastolics coming down. But a talk about blood pressure and what exact goals are is another day. Some other cardiovascular outcome studies that I saw that were not diabetes-related medicines, I just put a few up on the slides. And so we have shown benefits with ACE inhibitors and ARBs and spironolactone and eplerenone in patients who have congestive heart failure, and of course aspirin, and the importance of when we're talking about either primary prevention or secondary prevention, the number needed to treat are vastly different. When we look at people with diabetes dying, this is going to show the relative risk compared to the non-diabetic, which would be 1, and the bigger the box is the greater proportion of people. So we can see very high risks of dying from other things such as kidney disease down here, but we're going to see the biggest box is still really from cardiovascular disease, and I tried to highlight the ones that appear to be most statistically significant. I think many of these are not terribly surprising. I don't know if some people think about diabetes and cancer and diabetes and liver disease, but I think especially some of the diabetes medications and weight loss with chronic liver disease and non-alcoholic fatty liver disease is going to be one of the next waves of things that we're talking about. The UK-PDS was, of course, one of the first type 2 diabetes studies that looked at diabetes actually improving almost anything. And so this was conducted in the late 80s and 90s. And we did show that there was a decrease in the risk of, well, there's supposed to be a cardiovascular thing on the side, cardiovascular outcomes with declining A1c. And another study, this is again type 1 diabetic, so not applying to many of the other talks that we're having, but I wanted to put this slide out here because this is a purely glycemic control study. There's nothing else involved here. This is glucose control in type 1 diabetic, where when they were in the intensive arm versus conventional therapy, and this is conventional therapy that would not be considered conventional therapy now, we do see a separation, and over the course of really long follow-up, a substantial improvement with outcomes with improved glycemic control, but you do not see this separation for years and years. So glucose effect on atherosclerotic heart disease probably takes a long time. So I don't talk a lot, but when I look for tips on doing speeches, they say don't include slides like this. So this is the one slide that you're not supposed to include. We're going to talk about little pieces of this. This is just there for I don't have too many fun slides. That was supposed to be humorous. So going back to metformin and the UK-PDS, again, this is a primary prevention study. The UK-PDS took people freshly diagnosed with diabetes, and they got conventional therapy for diabetes at that point, which was to keep them comfortable and asymptomatic, trying to keep their blood glucose level under 270, versus more intensive therapies, which could include sulfonylureas, insulin, and metformin was given to the obese or overweight, not all. And over time, again, we're going to see that there's a separation. That separation takes a long time from pretty much doing any what would be considered current therapy before you start to get risk reduction for myocardial infarction. Overall death, very similar, starts to take a long time to get significant separation. More recent metformin study, this one is only from 2013, not too long ago. They took patients who had diabetes, took them off their drug therapy, and then put them either on glipizide at 5 and metformin 250 and titrated the dose up. If they didn't get to a goal A1c of 7, they would then add insulin. And the rest of the other drugs in terms of statins and ACE inhibitors and all that other kind of stuff was equivalent between the two groups. And they followed them out over the course of just 3 years, so not too long. But between these two groups, while the A1Cs were very similar and they did a pretty good job, but they didn't start too high in the first place, the composite cardiovascular events were substantially reduced with metformin compared to a sulfonylurea. And this goes along with some other concerns from past studies with regards to sulfonylureas really not having any benefit and potentially having some harm, where metformin may have some benefit. Metformin in congestive heart failure, back when I was in training, we were told not to use it because it could increase the risk of lactic acidosis, but an observational study done through the VA, followed for 2 years. This line is how soon people are dying, and they're dying less and less soon with metformin compared to other therapy. Didn't seem to have a big impact on CHF hospitalizations, but the deaths were reduced by about 24%. When you look at the subgroup analysis, people who actually had a lower GFR had an even greater benefit compared to those who had a completely normal GFR, and the benefit was seen more in the patients who were obese with a BMI of over 30. So I know there's been concern about metformin with heart and metformin with kidneys, and the number of people that I talked to who told me that their doctor took them off of metformin because it was hurting their kidneys, I think they're misunderstanding. I hope that's not the message we're giving people. I know the concern is metformin and lactic acidosis as renal function declines, but we're finding that it's really not that dangerous, and so the current guidelines are not to use it if the eGFR is over 45 at start. If you're already on it and your eGFR is falling now below 45 but still staying above 30 and you're doing okay, I leave people on therapy. Sometimes we'll cut back a little bit to 1,000 milligrams instead of a 2,000 milligram dose, but that's really about it. I end up monitoring them more than annually if I'm worried about their renal function. Iodinated contrast recommendations, I'm not going to have time to go into too much, but they're up there on the screen. And if anyone wants my slide deck, you're welcome to email me. I was going to start with giving you my email and phone. I'll do that at the end. Sulfonylureas, one slide, very brief. No evidence of cardiovascular benefit associated with weight gain, and compared to other diabetes treatments, substantially increased risk of hypoglycemia. TZDs, cardiovascular health, of course. Rosiglitazone got this all started in terms of diabetic drugs. Prior to this, it's, hey, blood sugars are better, people should do better. Meta-analysis came out. It's been debated, and rosiglitazone was withdrawn in 2010. It's actually been re-released / restrictions lifted in 2013, and there's some debate about how that trial was really done and how well that trial was done. And if you want to read the details about that, Steve Nissen, who did the initial one, has a nice 2 or 3 page diatribe against the FDA's handlement of rosiglitazone. In terms of pioglitazone, we have the PROACTIVE study, fairly large. We're getting to 2,000 plus patients in each arm with pioglitazone started at 15 milligrams and titrated up. A lot of these studies are white, very few ethnic groups, 98% Caucasian. 8 years of diabetes, average A1c of 7.8. We don't see a statistically significant difference. If we're going to see a difference that's going to be glucose related on cardiovascular disease from an atherosclerotic standpoint, remember, probably 6+ years most of the time. It does start to separate a little bit, so if they followed it out further, would we have gotten something significant? I don't know. But when we look at one of the major benefits, time to needing insulin, almost a 50% reduction in terms of progressing to insulin over the course of 3 years. We do see increased risk of congestive heart failure, and the issue is only just over 1% of the patients on pioglitazone actually had to discontinue pioglitazone because of congestive heart failure. Heart failure hospitalizations were nearly doubled, but we did not have an increase in heart failure death. And there's been some recent concerns about bladder cancer and other cancers with pioglitazone in this study. No statistically significant difference. Another study that's a little bit different than any of the ones in this is non-diabetics really. These are people who are insulin-resistant non-diabetics who've had a TIA or a stroke, also put on pioglitazone, pretty good numbers. And we do see that there is a separation, about a 24% reduction in the cumulative event-free cardiovascular disease survival. And it wasn't really from a massive decrease in stroke, although there was a 10 towards decrease in stroke. this is where we do see a decrease in MI and unstable angina with a number needed to treat of only 36. Insulin. So we have those initial type 1 diabetes studies. This is a more recent study. This is published in 2012. This is Glargine, relatively large study, over 6,000 patients. These were people who had impaired borderline diabetes or fairly early diabetes. A1Cs in this group, where was it down here? At enrollment was only 6.4%. So this is really trying to keep glucose control down. And they treated people for about 6 years. Timing of only choosing a 6-year study on insulin is odd when you have prior data that shows you're not going to see the benefit for over 6 years. And they didn't find the benefit. The only thing that was statistically different was a decrease in new episodes of angina by about 28%. Again, this is just highlighting the choice of 6 years is kind of a little odd for an insulin study. Alpha-glucosidase inhibitors have been around for a while. There was a meta-analysis with Acarbose, and for a while I said, hey, we're probably helping people with using this if they could tolerate it from a GI standpoint, because this showed time to events were less frequent with drug than with placebo. But this was a meta-analysis, and there can be some limitations. So there was the ACE study in Chinese with just over 3,000 people per group on the mid-dose, 50 milligrams, and they found no differences. And you did end up progressing to diabetes a little less frequently on therapy. Bromocriptine, I gave a speech 3 or 4 years ago that talks about some of these other drugs in more depth. This is one that has never really caught on, at least with me, even though the study came out 2010 showing, geez, if you just look at this big reduction in time to combined event, 79 people needing to be treated, why has this not caught on? If you look at what's going on here, baseline A1Cs were not very high. Very few people really tolerate this drug. Nausea in a third of patients, feeling tired, feeling depressed. There was no overall change in death, and the A1C in the treatment group actually went up by 1/10 of a point. This was not a brisk blood glucose lowering benefit. To use this drug is a little hard. It only comes in 0.8 milligram tablets, and every week the patient is supposed to go up by an extra tablet. So every day, week 1 tablet, every day, week 2 tablets, et cetera, up to 6-tablet dose. And by the end of the study, 41% of people were not on the treatment drug, and in addition to 26% of people on placebo stopping. I'm spending time talking about it just because it looks like it should be a big improvement, but no one's really using this that I'm aware of. DPP-4 inhibitors, these have become very popular just over 10 years. Easy to use, low side effect profile, I'll give it to the patients. In terms of cardiovascular outcomes with sitagliptin, there's basically no difference. One of the big things I took away from this study is we now have big studies with the pancreatitis concern that came out with these drugs long ago. We're seeing no significant increased risk of pancreatitis or pancreatic cancer with pretty big numbers of patients. Similar, the allogliptin study, pretty large numbers of patients, again, just highlighting largely white populations, no difference in adverse cardiovascular events, and similarly, no pancreatitis signal and no malignancy signal. And we move on to yet another saxagliptin, no cardiovascular benefit, similar benefits with no pancreatitis concerns. The issue with this trial is this is the one where they showed there was an increased risk of heart failure, and so they have a label about heart failure. The other major DPP-4 on the market, linagliptin, has a study that's supposed to be concluding around this time next year. So now we're on to the most recent and hot topic drugs. We've got SGLT2 inhibitors. So Empagliflozin, so this is the one that got people excited where the FDA changed labeling and that they can promote reducing cardiovascular outcomes. Again, pretty large studies, roughly 2-to-1 distribution between patients and placebo. Baseline, again, fairly largely white population. They do treat a lot of people who have had diabetes for a long time, so this is not a drug that you can only use when someone's just recently been diagnosed. And in terms of outcomes, there weren't major difference in terms of adverse outcomes. We worry about DKA, didn't see a lot of it. Hypoglycemia, didn't see a lot of it. The big difference was really the genital infections. This shows a tripling in men and basically a quadrupling in women of mycotic yeast infections. I've had women who have discontinued therapy due to recurring vaginal yeast infections, so this is real. I've only had one guy who had ballantitis that was thought to be from yeast, and when we talked about his hygiene, he actually went back on therapy and hasn't had a recurring episode. So I have not seen this 5% risk personally. I actually do inquire with men whether or not they're circumcised or not. as I think uncircumcised men have a much higher risk of that, and I do talk a little bit about hygiene when I start this drug. And that side effect is really not thought to be probably a chemical side effect of the drug. This is just what glucosuria does to people. Just to contrast this with upcoming slides, this one did not show a significant increase in the risk of amputation or fracture. And in terms of A1C lowering, when you have your drug rec come in and they tell you how well it lowers A1C and you see those short studies, 40, 50 months, hey, yes, it does a lot. When you extend it out further, the difference is actually pretty minimal when we're getting out to the end of the trial 4 years later. So a lot of this benefit may not really be strictly glucose related. And when you look at how long it takes glucose related studies to show separation, you see separation super early here. We're seeing separations in all term outcomes, so minus 14% in the all composite outcome, 38% reductions in death from cardiovascular causes, and including the hospitalization for heart failures, we're seeing improvements here. Separations are all early. This is probably not a glucose-related effect. Renal outcomes, so this class of medicine I start looking at more and more for patients who have albuminuria. We're going to start to see decreases in worsening nephropathy and all-come renal outcomes with empagliflozin. The other major one, the first one actually came to market, was canagliflozin. Another big study, 4,000, 5,000 people in each group. Again, diabetes duration fairly long. And when we look at adverse outcomes, similarly, we're not really so much worried about hypoglycemia or DKA. We again see the roughly tripling of mycotic genital infections in men and quadrupling in women. UTIs were not significantly really increased in either group, but this study did show a small increased risk of fracture, small in terms of absolute numbers, and fractures as well that were not seen with empagliflozin. In terms of the outcomes, similarly, hey, we lower A1C a lot, yes, follow it out, a lot of that benefit goes away. This is where we're still probably having to do add-on drug therapy or continue to push patients for additional lifestyle modification as time goes by. People do lose weight, blood pressure does come down, and in terms of the cardiovascular outcomes, again, it's in this 13, 14, 12, 15% range in terms of all outcomes coming down, not statistically significant in any of the individual categories. So we move forward. Heart failure is where a lot of this comes from. So it's thought that these SGLT2 inhibitors probably have more hemodynamic effects, and there's lots of other thoughts about why these may be working, proposed mechanisms, oh, these are probably unlikely, these are likely. No one really knows. Unfortunately, I'm not going to spend too much time because no one really knows. There are a few more SGLT2 studies that are still coming, dapagliflozin, and just on the market, their study is going to be coming up too. Incretins, so these came out just as I was finishing my training, and we have exenatide twice daily, which was the first in class. A meta-analysis basically tends to show a trend towards decreased cardiovascular outcomes, but nothing really ends up being statistically significant when they analyze the same data in a variety of different methods that are beyond my level of discussing those. When we come to the recent studies, and these are the longer cardiovascular studies and these GLP drugs, there's one that's going to be still done. It's a drug that I'll have another slide about later, but not from a cardiovascular standpoint, but a rewind study on dulaglutide, which is the once weekly, goes by Trulicity, that's been on the market for a little while, but their cardiovascular data is not out. And I found this review slide that just kind of highlights that these are relatively short studies. Again, when we're looking for glucose effects on atherosclerotic disease, we're often going to think about needing longer studies. 2 years on drug, 4 years, 3 years on drug therapy. And I decided to talk about these just in the order that they were on this slide. Lixazenatide, many of you may not have heard of. It's not available independently in the United States, but we do have it in a combination with insulin. It's on the little list if you go down and look on the handout. In terms of actual A1C lowering, this is a lot less than we're seeing with some of the other GLP-1 analogs, and we did not see cardiovascular benefit in this study. Also, fortunately, did not see, again, pancreatitis or pancreatic cancer concerns. Leader, so this is liraglutide, 4,000 plus patients in each group. And we, again, initial A1C lowering, benefits start to wane, people lose weight, the weight loss stops. So I have had a few people say, oh, this is great when I went on therapy, but it stopped working in terms of them continuing to lose weight. These people are not going to lose weight forever on these drugs. So when they lose weight over the course of 3 to 6 months, I'm really thrilled, and then keep pushing them on the diet and exercise, keep them motivated that, hey, I'm on the right path. About 13 years of diabetes, A1C is closer to 8.7, and again, we're not seeing concerns with pancreatitis, hypoglycemia, et cetera. There was a slight increase in gallbladder disease. In terms of the pancreatitis, not all amylase and lipase elevations are pancreatitis. So the patient goes to the emergency room, they get the whole bunch of stuff, and they come and they see me and like, I had pancreatitis because my lipase was mildly elevated when you track down the numbers. So we do see that almost with all these drugs, the lipase and amylase levels go up a little bit, but time to confirmed pancreatitis versus placebo is not statistically different. In terms of the cardiovascular outcomes, again, overall, around 13% in the all cardiovascular outcomes. And when you break them down, there's more of them that end up being statistically significant in reducing adverse cardiovascular outcomes, including death. So this is why a lot of people got excited, and there's been a push for Victoza as a cardiovascular drug as well. Semaglutide, so these are going to be all pretty recent studies as well. This just came to market. I have just got a couple samples in my fridge just recently. But about 1,600 patients, like 64, even longer duration of diabetes, out to about 14 years. We're seeing, again, in only a 2-year study, fairly dramatic A1C lowering, stronger than we're seeing with some of the others. But again, even there, the benefit tends to wane. And we do see even a little bit more weight loss than compared to some of the others. One of the things that came back is a non-statistically significant increase in retinopathy, and the thought on this is that we do have other studies that show very rapidly making big drops in glucose control can temporarily worsen retinopathy, and they didn't see any retinopathy cases in people who had none at baseline. And again, this wasn't statistically significant, but something that they're keeping an eye on. Pancreatitis, I forgot to add them in here, but there was no significant increase in pancreatitis with yet another study. Cardiovascular outcomes, only statistically significant in a couple of spots, but again, 26% reduction in the overall primary outcome. And maybe some benefit that we didn't see necessarily with the other drugs with the statistically significant in stroke, non-fatal strokes. So exenatide has been around for a while as the twice daily dosing, and then more recently came out with the once weekly extended release version. Big study, we do show A1Cs going down, coming back up. All these curves are at least shape-wise mimic each other. Here, when we look at body weight comes down, but they actually don't maintain the body weight nearly as well, maybe. They're back up to baseline. Compared to placebo, only a small improvement over the course of the study. And we do see that systolic blood pressure does drop a little bit with these drugs. Again, no significant increase in pancreatitis or pancreatic cancer. This is one of the few studies that also decided to mention medullary thyroid carcinoma, but really no significant increase there. In terms of the cardiovascular outcomes, unfortunately, no statistically significant differences until we look at death from any cause, and there was a reduction here. So there are some thoughts as to why this may have occurred in terms of the patient population and the number of them who had coronary artery disease. Some of the other studies are almost 100% with cardiovascular disease, and this one had slightly less. And this study started off at a slightly lower A1C than some of these studies at 8, as opposed to some of the others are more in the mid-8 range, as possible reasons why they didn't show any benefit. But when you look at a meta-analysis that looked at comparing all these studies on the GLP-1s, we do see that there tends to be a trend, other than that first one that we talked about, towards overall improvement. So when we're choosing these head-to-head, these are now non-cardiovascular safety studies. And this is one I showed 3 or 4 years ago, but these are short-term studies just on efficacy, and so because we don't have too many head-to-head trials, but this is liraglutide versus exenatide, and liraglutide was more effective in lowering A1C. And when we looked at another study, again, liraglutide was a little bit more effective in lowering A1C. And this is a really, April 2018, I had to actually pay for this article. It's not out yet in print, but I found it when I was looking for stuff. And this is, again, semaglutide new, dulaglutide, which their individual cardiovascular outcomes are still going to come out. Their trial ends in about a year. Just a short-term 40-week head-to-head glycemic control trial. And this is just highlighting that right now it looks like semaglutide is the most potent GLP-1 that we have for glucose lowering, with A1Cs lower at both doses compared to comparator, and more weight loss, and more weight loss. So this was my last slide, and if I knew I was going to go this fast, I actually had a few more that I could have put in. But this is how I guess I'm thinking about it. If you're starting from the concept of you're walking into the room with a patient who has not only diabetes, but has known cardiovascular disease, assuming they're either on metformin or they can't take metformin for some reason. Things that I think about, and if they have congestive heart failure, we're probably not going with pioglitazone. We see the biggest benefits from the addition of the SGLT2 inhibitors. If they're obese, we're probably not going first line with pioglitazone, but we'll probably get some benefit with weight loss with both SGLT2 inhibitors and particularly GLP-1s like semaglutide. If they have decreased kidney function with the eGFR of less than 45, we're not supposed to be using these, and we can be moving in this direction. And if their fluid balance is okay, I will still consider possibly pioglitazone. History of stroke, we've shown that there's a pioglitazone study that shows some benefits, and we've seen that there may be some benefit with semaglutide as well. And in terms of non-alcoholic fatty liver disease, at this point, there may be some evidence that pioglitazone is the way to go, so I'm actually putting even some obese patients, but when it looks like their non-alcoholic fatty liver disease is getting worse, the transaminases are just going up, and up, and for no other reason, I'm putting people on pioglitazone, and I'm seeing those transaminase levels often come down. Recurring yeast infections, probably staying away from these and being more on this end of the spectrum. And then when we're going to the individual drugs, again, based just solely on the cardiovascular studies I've presented, if they've had a history of amputation and you're choosing SGLT2 inhibitor, the actual risk from canagliflozin is probably pretty small. It's just you're dealing with a patient population that's going to be pretty high risk for amputation. So if they've already lost a toe, I'm very nervous about putting them on canagliflozin because already they're at increased risk for losing another toe, and then they're going to see an ad from a lawyer saying if you lost a toe and you're using canagliflozin, come call me. And it may not even be related in that standpoint. So in that situation, I'm going with empagliflozin until we get more data about some of the SGLT2 inhibitors. And this is all ideal world. I spend a long time weekly doing prior authorizations to try and get all this stuff done. The GLP-1s, a lot of this maybe starts with patient preference. Some of them are going to have a hard time with weeklies. They just can't keep up on something. They do erratically. Some people just, hey, it's in my morning routine. I do a morning dose. If they're doing a morning dose, I maybe go with liraglutide. Since semaglutide had that little bit of concern about retinopathy, maybe going with liraglutide. But these are some of the things that go through my mind when we're trying to choose between which of these drugs to add on to a patient who has both diabetes and cardiovascular disease.
We'll take a few questions just so that the general audience can hear before lunch, but Dr. Nakai is going to be available during lunch in a breakout session where you can tag in with your more specific questions. But let's take a couple just to see where the interest lies in the audience. So somebody has one. Okay.
That was it. That was easy.
Right.
Hello.
Oh, no.
Sorry, one question over here.
And so if you have a patient and you're wondering about something, and I know unfortunately, hey, they have thyrotoxicosis and I don't want to wait the 3 weeks to get in to see you. And fortunately, our wait times are getting down. Here today, and hopefully you get to meet her, physician's assistant Heather has just joined us, increasing the number of patients we can get in. We're trying to recruit some more doctors to join us, and we are, as Dr. Dunlap had mentioned, this kind of multi-specialty approach. We are trying to have a doctor-driven doing consults and supervising nurse practitioners and physician's assistants with diabetes educators as a way to really kind of help cover diabetes and other endocrine causes, especially with this surge of new technology. We've got pumps evolving very quickly in the last few years, and the most recent pumps from Medtronic are very exciting. We've got direct-to-consumer continuous glucose monitoring taking a big jump now that Medicare has decided to help cover that for the Medicare patients. And we need all the assistance we can have because I'm not going to sit there spending time training them on how to appropriately use their sensor. And if you want to prescribe patients with sensors, you can even just refer them to our diabetes educator so they can get trained on how to use their sensor appropriately. Because there's more to it than just sticking it in. It's then what do you do with the glucose information once you start seeing it?
It's a quick question about you, about folks. Sorry, over
I
here.
can't tell where we're going. Yes.
Yeah. I struggle with the question of folks who have an A1c of 6.4 or so, and the decision about, after, of course, exercise and diet counseling, is if they want to try a metformin or something like that for essentially pre-diabetes.
Okay.
That's counseling I've struggled with. What do you typically tell patients?
So I'm always going to start off with, I look at A1Cs to some degree. I look a lot at blood glucose readings, and this is with the assumption that this is not an anemic patient with sickle cell disease or thalassemia where these A1Cs may be false. I do every year I get a couple of people who I've been fine, my A1C is 6.2, they've got all these complications and they've been chronically anemic with one of those problems. So just making sure that you really believe the A1C is 6.2 and all their fasting blood glucose levels aren't 200. But I really do focus on the diet and exercise part first. I tell them that we have the diabetes prevention program that shows that if they do diet and exercise well, it outperforms metformin. We unfortunately didn't have a combination diet and exercise intensive group with metformin in that trial. I will say that I have a fairly low threshold for the patient who really wants to do the most that they can, and they are really making the efforts at the diet and exercise, and they want to reduce their risk, especially if there's a reason. So they come in and their family has early heart disease, and they want to do as much as they can. They have relatives with diabetes who have shown that they have complications. You know, my aunt's blind. I have friends my other family members who lost toes. I do tend to get very aggressive. And the other thing is, if you've ever seen my notes, I track back and I plot out how they're really doing. Because the problem with prediabetes is that it's a risk factor for developing diabetes and worsening complications, but not everyone progresses the same. And so if I look at that person and I can see that their A1C was 5.4 when they had a routine health screening 4 years ago, and they jumped up to 5.8 and now up to 6.2, and they're trending up, I'm going to be much more apt to consider offering that patient therapy as opposed to someone who you look back and they're 6'2", 6'2", 6'2" for like a decade. What are you going to really get out of doing that unless they have other risk factors?
How close is artificial pancreas for type 1s?
I don't do the research. I see with these things when they start coming out. I will say that the most recent pump is really exciting in the sense that the continuous glucose sensing is getting better and better, that we've had several patients who are pump veterans and have been on modern pumps who have transitioned to the new pump, which goes into auto mode if glucose isn't excursioning too much and they're doing certain things. And we've seen rather dramatic improvements. So I do think that we're moving closer to that. I still get very leery for people who are not technically savvy, who are really not making lots of effort at their diabetes, who are referred to me for a pump as if it's going to fix it. I've had patients come in where I was told to ask you about this, and I say, well, how do you feel about using your smartphone? I don't even have a smartphone. I don't like those. These people are not going to do well with these new pumps. There's actually a lot you still need to be involved in actively doing. And the current pumps, I don't see how we're going to really get away from needing to know how to bolus for insulin in type 1 diabetics. These current pumps are really good at taking care of the basal background, everything that's in between the food. But food makes blood sugar go up too fast for our current insulin and pumps to keep up with. So by the time we get to a point where you just stick a pump on and it really takes care of everything and you're not worried about the food or telling your pump in advance you're about to go to the gym, I think we're probably a ways away from that.
Okay, thank you very much. Let's cut it off there. If you want to have more questions, Dr. Nakai is available over the lunch hour. Let's plan to come back here at 10 minutes after.